First and foremost, never accept a bill before looking at the bill, judging the bill, and probably disputing the bill.
Today, I'm so happy to welcome Dr. Fernando Branco, Chief Medical Officer of Midwest Employers Casualty. Welcome, Dr. Branco.
Well, thank you, Kaya. Thank you for this great invitation in such a very, very important topic.
Yes, before we dive in, will you tell us a little bit about your background and how you ended up at Midwest?
Oh, I've been a clinician for 30 years. I graduated in the mid-'80s. I think now everybody can sort of guess my age. And after that, I worked for 30 years in clinical practice. I did a residency in physical medicine and rehabilitation. And as I work with this kind of patients, I also noticed that I probably should learn a little bit more about pain. And I became board certified in pain. And because you guys know that we had a narcotic epidemic for last 25 to 30 years, that now it's finally winding down, I decided also become certified in addiction medicine. And that's what I practiced for my last 15 years, all three of them.
And today, this is so critical in the work comp world, especially, and it's something that often gets overlooked because we're often thinking of, at least in the restaurant world, the slip, trip, and fall, and sometimes it gets overlooked of the addiction that happens when someone is given an opioid for pain. And so I imagine that this has become a very important thing over the last several decades with you.
Absolutely. And the thing that's important about that is that 98% of the time, you have a fall and there is some injury and the doctors do a good job and the person gets back to work. The problem is that the 2% that keeps lingering and then it keeps going back and back and back, and we do the crazy surgeries and the right surgeries and the right procedures. And in the past, the paradigm has shifted. In the past, we used to have the easy solution for all the doctors was, I don't know what else to do with you, let me give you narcotics. And that was the standard practice. It created a lot of problems, not just financially, that was terrible, but also for the patients.
And this is a good segue to talk about our topic today, which is medical inflation. Will you first give us a high-level picture of medical inflation and what you're going to talk about today?
Medical care always been expensive. We know that, hospitals and doctors like to be paid well. I'm a doctor. I know how it works. But lately, what used to be a slope of increase, it became an exponential increase. As a physician, I'm absolutely flabbergasted sometimes with the charges that come. I don't even know if some of the physicians that are actually doing the procedures understand how much is being charged. And we'll talk a little bit about this, hopefully, in a few minutes. Why is it that doctors are even detached to this billing piece of this whole process? Because in the past was more the doctor doing the billing. And now, unfortunately, it isn't the doctor, but it has increased exponentially in the last 10 years, in the last 5 years, even worse. And there are some reasons for that. And
what would you say is driving this medical inflation?
Well, I'll go back into the problem that we just mentioned. There was the narcotic epidemic that created, to a certain degree, a dependency of millions. We calculate now between 20 and 30 million people that are dependent on the medical care system, including hospitals and doctors and pharmaceutical companies with their drugs, their procedures, their follow-ups. And these were young people we're talking about. We're not talking about the regular elderly people that need care. We're talking about the 25 to 45 years olds that are now dependent on the system. And the system made a lot of money out of that. What happens when the paradigm shifted. It shifted, and boom, now we don't have all these patients. Now they're all coming out of these drugs. They're not using these drugs. And how do we maintain the flow of money? There's a lot of things that have been added. A lot of them are new medications, and some are fantastic medications. They're out there, medications for cancer, medications for chronic diseases like psoriasis, all sorts of things. And most of those drugs are very, very good drugs. The problem is they have to make up the money that they used to make. In these pills, they get absurdly high prices, and we know that the American public pays for probably around 80% the profit of most drugs. And I think we all know about that. We're not going to go into the details about that because it gets too heated up. But the issue is that other countries don't pay. We pay. And one of the things is that all these new drugs, all these new procedures that are coming in, ketamine injections, new electronics being installed on patients, all of this is increasing the price of medical care. And regular procedures have increased in price quite dramatically. Also, we have this idea that COVID didn't change everything, but COVID did change things. The whole world went crazy. We had the post-COVID inflation, natural inflation, regular inflation, right? That we all expected to happen. And that, I think, it sort of got stuck also into the medical area, but it went into an excessive inflation in the medical side. And also, I think what ended up happening with this, and I'll tell you, I grew up as a kid in a country that had an inflation of 1,000%. And what happens when you have a lot of inflation is everybody's trying to catch up. I call like a game of chicken. Then I'm going to increase, because if I don't increase, the other increases. And then this price thing becomes kind of this way. If the hospital says, well, if I don't increase, then I don't get paid, because then the other side won't pay, and then my money, my providers will increase. It becomes a self-feeding process.
Right. And to tie it back to workers' comp insurance, which is what we do, we've got the workers' comp self-insured group. When we're always trying to explain to our members what you can do to mitigate your costs, what you can do to do loss prevention, to lower the instances of claims getting litigated. How do you take care of the employee? So from your perspective, are there any things that the employer can do to mitigate any of these risks that are facing them?
Yes, there's definitely several things that can be done. I think just to add what you mentioned in terms of workers' comp, why is it that we are more at risk of this medical inflation? And we are, because one of the differences are have been in both sides of this equation in here. Hospitals see patients, if they don't have the money, they're not going to go after them. Big insurance companies, the hospital that I go to every year, they fight with my insurance company, and I don't get coverage for a couple of months over that, blah, blah, blah. That means the big insurance, they know how to do it. Unfortunately, the workers' comp, we don't have that kind of how to do this wheeling and dealing, right? And on top of it, we're very litigious. That means a lot of times the judges and the lawyers force us to pay, and then the hospitals look at that, and I remember being in the hospital and say, hey, workers' comp, they have to pay whatever we charge. That means keep in mind that we are the golden goose of paying. And that's why it's so important to do things to try to avoid these things, even so we are the target of it.
I'd love for you to give us some actionable steps that employers can take.
Absolutely. One of them that it goes for every case, is early intervention. Be a catastrophic case, be a simple case. Never assume that, oh, yeah, this is just going to resolve yourself. That's why it's so important to have a good TPA involved. Also, very important, if necessary, we don't need it for everybody, but if the injury is severe enough, to engage a nurse case manager to coordinate care, because sometimes people think, what's the point? You put a nurse case manager in there, and the only thing they do is follow and look and go into the meetings and everything. No, 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 no. They really look at the whole thing, and they start. If they see red flags, they let us know. They're on top of it. They create a relationship with the patient before he becomes litigious a lot of times, because we know that litigation is one of the worst things that you can ever have, because then we lose a lot of control. And actually, it's worse for the patient, because it doesn't really, the best treatments are not necessarily be given. That's one of them. Another thing,
I
yes,
agree with
please.
you on that one.
Yes.
We find that a lot, that sometimes just the fear that sets in when they're not hearing from someone, when an injured worker just doesn't know what to do. And so then they get in touch with a lawyer, and then it becomes litigated. So I definitely see that one. What else can an employer do?
Well, one important thing is you're going to have let's say you're a nurse case manager, your adjuster in there. And these are people that hopefully, now we have AI that can also help with the adjuster and the nurse case manager to sort of open up their minds. I hate the idea of using AI as a substitution, because it never will substitute my adjuster and my nurse case manager. But the AI can really help in terms of opening some things that maybe the adjuster hadn't thought about it, or the nurse case manager, because you need to look at the whole picture in here. What about comorbidities? Is this person coming into this? Most of us are not ultra healthy, right? We're not all perfect. We have our issues from before, be psychological, be physical. And any injury can disrupt all of that. And then you need to be very, very careful to avoid having these things in the beginning or at any time to get engaged into the file. However, sometimes if you don't treat them, you also create a problem. Because if you have somebody that had severe depression in the past, the next thing you know, they get a PTSD diagnosis. And you didn't need that. And for that, you need to probably give service, but not take over the diagnosis.
So we aren't scheduled to talk about AI today, but since you brought it up, I am interested to hear how you guys at Midwest are utilizing AI in this area.
AI for us is an assistive tool. So much that we don't call it artificial intelligence. And Ben Birch will discuss that in details. He's one of our geniuses in here. And we call assisted intelligence, because that's what it should be. It's not here to substitute human beings, because humans bring a completely different approach to the table. What it does is save you time. Let's say you have 500 pages of records, you're still going to go over those records, right? But you might miss something here and there because you're human, and the AI will help you with that. Also, sometimes maybe you think about some recommendations or some actions, but maybe you forgot one. AI is so much more detail that sometimes that can be helpful. That means for us, it's called assisted intelligence, and that's how I see it.
And Midwest is nationwide, and we're only California, which is an animal unto itself in the work comp world, as you know very well. Yes. What, if you had a crystal ball to tell us, what are the biggest risks and what are the biggest opportunities ahead for us as an insurance company that will benefit our members around this medical inflation?
The things that you should prepare yourself, I think, definitely We discussed already the data analytics. I think you need to make sure that you have some good vendors working with you, because remember the chicken game that I was talking about? All the hospitals are playing and all the doctors are playing. And it's not so much the doctors, as I said. I don't know if you realize that since COVID, the vast majority of doctors, thousands and thousands, retired, and literally millions join big corporations, health corporations. Now what you have is this enormous corporations that know how to really dealing and willing, right? You need somebody on your side, and we have a couple people that we work with that can really do this bill review and discuss, and not just do that, that simple thing, just push the things through and check if it fits the state code. It has to be a much deeper, like, for example, if you are in California, get somebody that specializes in California, know the providers, the big providers, because one of the things is you say, I don't want to pay this $800,000 bill. But if you know the managers that work in certain offices, and some companies do, and you are able to make good arguments, and you bring it up, a good ways to do this discussion without being, it will be confrontation to a certain degree, but not, to the point that the other side is just going to say, I'm not dealing with you. It has to be done. But I think one very important thing, definitely you need somebody, not just a bill review, because bill review, everybody does bill review, right?
Right.
I think, you go to a meeting and everybody does. Try to find good companies, and we have a couple that we really trust. In general, they're smaller, they're more focused, they're more state-wise, wise. That's one of the things that I'd say you could use.
Dr. Branco, I'd love to hear your opinion about how longevity and medical outcomes are going to impact the work comp world in the coming decades. Because as you know, when we would do our projections out for how long we're going to pay long-term disability, and actuaries would look at short-term disability, it used to be shorter, and now people are living longer. There's more treatments out so that someone's longer, and great. We're super happy for those outcomes from a human aspect, but then there's also a realistic aspect about financially. What does this cost a group, and how do we plan for that? From your perspective as a medical director, can you give us just your high-level opinion about this?
The interesting thing about is, because obviously you're extremely knowledgeable, because you almost answer your own question. You pretty much sort of describe the whole situation is the truth. Obviously, there is a piece that we are living longer, but some is not as much as that. I think there is the longevity of the normal population, but there is also the longevity of the worker, because our workers are working longer for all sorts of reasons. That, my God, I would have to spend an hour here to talk about all the reasons why workers are staying at work much longer. But they are. That means the older you are, I know, so look at me, I'm an old guy, the more problems you're going to have. There is no doubt. And then if something goes broke, 3 others go broke at the same time. It's like when you are like 20 years old and you go to the gym and you pull a muscle, and then 2 days later you're back at the gym. If you are my age, 60-something years old, you pull a muscle, you're going to wait 2 months before you can get back to the gym. It's just the way it is. It's not just the longevity, also the employees are getting older. And then you also hit, that's why I said you have the answers already. There are now, fortunately, a lot of new drugs. That amazes me that the pharmaceutical companies have been able to do so much research and put so much together. And they must have sped up this process as maybe the narcotic money start going down, they says, hey, we need to push all this to the forefront, and they did. And there's some amazing drugs out there, not just a few, dozens of new ones. Be for headaches, they're very expensive, but very helpful. But also some that are almost impossible not to approve. There are drugs for cancer, as I would like to mention one that has changed completely, more than one actually. The prognosis of multiple myeloma, that was a death sentence to anybody. You would die in 2 to 3 years. And now I have a patient that's alive for 15 years.
Wow.
With multiple myeloma. Absolutely, that is going to affect how we reserve. And that's one of the reasons, at least internally, we do a lot of what we call roundtables, and we analyze a lot of the files. I'm directly engaged. I have 6 nurses also that are heavily engaged on these files. And as soon as we see this kind of, or cancer, or a new drug, or this or that, I will do a deep analysis, and then we work with the group to make sure that we're reserving appropriately. Yes, you're going to have to adapt to that. That is a true reality.
I agree with you. I see that we could talk for 45 minutes on it, because now you just brought up another thing I want to ask your opinion about, and that is the cost of pharmaceuticals. As you know, I'm very familiar following Mark Cuban's new cost plus model, where he's trying to disrupt the pharmaceutical industry. There's many people. Back in the day when I was working for a congressman, I helped to get a legislation passed that allowed MS patients to get a certain drug that wasn't being allowed until someone was no longer ambulatory. So they were waiting till the disease progressed so much that they couldn't walk anymore. So just the illogical and inhumane decisions that are made every day on pharmaceuticals, and who gets them and who gets access to them and how they're priced. And yet I see the other side of it, where I just finished a program at Stanford, and we were talking about, creating drugs and inventing drugs, and that how much cost goes into that, and shouldn't these private drug companies be allowed to recoup their cost after? So it's a very hard argument, even though they're also subsidized often by the government. So I'm familiar with all the different arguments, but I'm really more interested to hear your perspective on what's happening in the drug pricing world.
Again, I think you were so well informed that it's kind of hard for me to add so much to what you just said. What I mentioned before is that the reasons are not up to me to be discussing in here, but the vast majority of the profits that need to be made, as you clearly stated, because America pretty much creates most of these new drugs that we need. We're saving people. These are, when I see these drugs and working, I was like elated, because I lost so many patients with multiple myeloma in a couple of years. These are young people, vibrant. Who knows? Maybe we can keep them alive and see their kids graduate. That means this is amazing. But how this can be resolved? I personally don't have a solution, but we needed to have a price that is reasonable enough that the insurance are not going to go broke, right, that the patient is not going to go broke for paying for this medication. Some of these pills cost $30 a pill, $50 a pill. I have infusions now that cost on average $15,000 an infusion, and you're going to do it 2 or 3 times a month. That means, right, how is this possible? That's not possible in no real world. In other countries, at least in my limited experience, is because they have the systems, they say, we're just not paying, Right. And then because in America, it's one way or another, or people pay from their own money, or the insurance get pushed, and workers' comp also gets pushed to pay for. We end up paying this exorbitant amounts of money. But you're absolutely right. We need to compensate the pharmaceutical companies, because if we stop, we're not going to have drugs.
Right.
If they don't have the money, we don't have drugs. And we don't want this to stop, because this is what's making us live longer and longer and have a much better life quality.
Yep. It's the ultimate catch-22, isn't it?
Yes, it is.
Yeah. Okay, before we go, Dr. Branco, can you give us a couple takeaways that a restaurant owner can do or know this week about medical inflation?
Yes, something very short, just to hopefully to stick to your mind after this conversation. First and foremost, never accept a bill before looking at the bill, judging the bill, and probably disputing the bill. Because in today's system, we have to do that. It's unfortunate. Also, be updated in what are the new treatments. Even for simple injuries, doctors are injecting all sorts of strange procedures, more expensive procedures. Just be updated. And if you don't know what it is, hey, you have AI, go read a little bit more. Is that appropriate, not appropriate? And be proactive. Don't wait. Don't be reactive.
Thank you so much for your time.
Thank you so much, and I'll definitely be looking forward to another conversation. Maybe we'll have more time. We can discuss a little bit more. I love to talk about these topics.
Excellent. Thank you. Have a wonderful day.
You too.